Over to you, sir.
Thank you. Good afternoon, doctors. Welcome to this webinar on the role of oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Hetero Healthcare is one of the largest closely held pharmaceutical company in India and is among the largest manufacturers of ARV, APIs and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Hetero Healthcare was awarded Award of Pharma Excellence for COVID drugs. Today's webinar role of oseltamivir in flu management, we have got Dr. Pramod Zog as moderator and Dr. Anil MU as speaker. Welcome, Dr. Zog. Welcome, Dr. Anil. Dr.
Thank you.
Pramod Zog is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. And Dr. Anil MU is MBBS MD Pediatrics with fellowship in Pediatric Critical Care, Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care, Spurs Hospital, Bangalore. With this brief introduction, I hand over the session to Dr. Pramod Zog. Over to you, sir.
Thank you. I will just share my screen.
Yes, sir.
Just yeah. Okay. So I hope the screen is visible.
Yes, sir.
Yes, sir. Yes, sir.
Yes. Oh, thank you. Okay. So good afternoon, friends. Today we are going to discuss an important topic related to the use of oseltamivir in flu management. And you can see that I put up my name in the fashion of the influenza virus, which is called as nomenclature of the influenza virus, which includes the place of origin and the year of origin and so on. And as far as I am concerned, I was the IAP presidential strain of 2016. And every year, just as the influenza virus changes, even the strain of the IAP presidents changes. Okay, of course, this is in a lighter vein. Anyway, I am glad to have Dr. Anil from Bangalore, intensivist, with me to discuss different aspects of influenza and the role of oseltamivir. So we will take you through some important aspects of this subject over next 1 hour. And in case if there are any queries, please feel free to put them in the chat box. Everyone is aware that influenza basically is a problem which we face during monsoon, just as we have respiratory syncytial virus, we have some arthropod-borne diseases like dengue, which are at the peak during monsoon. Influenza is also at its peak during monsoon. But we have seen influenza cases all around the year. And in certain parts of our country, like Kashmir and Kanyakumari, these cases are seen particularly in the months of November and December. It all depends on the geography. And, the earth has been divided into northern hemisphere and the southern hemisphere. And there is a lot which is discussed about the epidemiology of influenza related to these hemispheres. And this is also related to the vaccination and which vaccines and which vaccine containing which strains are to be administered to children. It's important that viral infections are rather taken up in a bit of a serious manner now. Gone are the days when we used to think that, viral infections are not so dangerous. But after H1N1 pandemic of 2009 and the COVID pandemic, which went on for almost 3 years, now we are worried whenever someone says it's viral. Why we are worried is initially we thought that virus will always produce a problem for a short duration of 3 or 5 days. But the cytokine related problems, the cytokine storms, are something which are creating a lot of worry. And we have seen that after 4 or 5 days, some of these children with influenza or some of the children with COVID-19. So, we have seen them worsening. And that's why, some of these illnesses, which are biophysic illnesses, that second phase, even in dengue, as we know, on day 4 or 5, the second phase begins, and then the problems they begin. So one has to be very, very cautious and see that a child who is seen by you today in the OPD is called for a follow-up after 4 or 5 days. Already you know that he is not worsening. So these viral infections are on the rise, and even older children are getting affected. And probably this is because during COVID, some of these infections, they did not have an opportunity to attack children, neither the adults, and that's why immunity did not develop in these groups of patients, and this is what was referred to as immune debt. And of course, this is something which we can explain and tell the parents also, that the children have not had this, immunity against some of these viruses, and that's why they are developing some of these infections. In the post-COVID period, there have been waves of different viruses. So we witnessed respiratory syncytial viruses. Then in some period, we, witnessed adenoviral infections. In some places, we witnessed measles outbreaks where vaccination was on the lower side. Some of us, we also saw waves of hand, foot, mouth disease. So all these viruses, they, are the ones who never had, opportunity to attack the children during COVID. And then after COVID, some of these viruses, they started showing up. Recently we had a 3-year-old boy with fever, cough, and cold and progressive breathlessness over 3 days with tachypnea and hypoxia, and the X-ray showing a picture like ARDS. He was admitted to the PICU, was ventilated, and then he received oseltamivir, supportive therapy, and then the throat swab report showed S3N2 positivity. He was ventilated for 3 days, and then he was all right. Now, after this particular case, we started discussing whether a previously healthy child presenting to us with cough, cold, and fever and progressing over 3 days, whether a treating clinician can prevent this particular progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront, particularly in the flu season. Okay, and of course, we'll be discussing this in our discussion today. So there are certain points which are confusing points in relation to influenza. And that's why I say these are confusing points. And we will have to discuss whether a given infection is bacterial or viral, whether this virus is a rhinovirus, adenovirus, influenza virus, and if it is influenza, whether this is H1N1 or H3, and whether I should start oseltamivir upfront. It is important to note that during monsoon, all these so-called influenza-like illnesses, they gallore. And I always say that influenza is the father of all those influenza-like illnesses, because it's something, not only a bad cold, because it is beyond that. It is a systemic illness, like it will have headache, weakness, the child will have pain in the knees, and to the extent that the father has to lift up even an older child and get him to the OPD for treatment. And one can make out that this is really something different. Though it's a respiratory virus, it is behaving a bit differently. It is important to suspect this. This is because we have oseltamivir, which is a molecule which needs to be given as fast as possible within first 48 hours, so that the further problems related to influenza are prevented. Also, it is important to note that the incidence of influenza and related deaths are increasing alarmingly in India. As regards the KYC of this virus, KYC is the know your customer. In the bank, we have to submit all our details. Similarly, one must be aware of all the details of this virus. As I told you, this is the virus which changes its structure every year. And, this is because it's an RNA virus. RNA viruses usually are known to change the structures. COVID-19, RSV, all these are RNA viruses. See that viruses are either RNA viruses or DNA viruses. We all know that, and for survival, any virus will require both RNA as well as DNA. As it doesn't have DNA, when it goes and attaches itself to the respiratory epithelial cell, then at that time, it will take the help of the host cell to reproduce its own copies which are similar to its own. Like, it will produce RNAs with the help of the DNA of the host cell. Now, this influenza A is the one which is responsible for frequent epidemics. Every year, whichever cases we see mostly are related to influenza A, and the change of the viral strain usually is seen in this influenza A. This is because there are some amino acids in the glycoproteins which are present on the outer side of the virus, which keep changing. As I told you, it's an RNA virus and it is known to change, every year. The periodic pandemics are all because of influenza A viruses. That is because influenza A attacks the human beings, birds, animals, and when one type from the bird and one type from the human beings gets, a chance to combine in a third party, like a pig, for example, the pig acts as a mixing vessel where both these viruses, one from the bird, one from the human beings, it mixes, and a totally new strain, which we had novel influenza virus of 2009, that comes into existence. As there is no immunity in the community against this novel influenza, there is, spread of pandemic. This is what exactly happened in so many pandemics which have occurred till now. On the other hand, influenza B virus infects only human beings. And that is why it doesn't produce pandemics, though it produces local epidemics. As I was trying to tell you, those glycoproteins on the outer side of the influenza virus are of two types, hemagglutinin and neuraminidase. Hemagglutinin is the molecular key, and that is the one which is responsible for attachment of the virus to the respiratory epithelial cell. The virus gets attached to the respiratory epithelial cell with the help of this particular hemagglutinin. As I say, it's a molecular key. The RNA, is able to enter inside the respiratory epithelial cell. Then, as I said, it will dictate the DNA, produce similar copies, and all those RNA particles, in huge number are present inside the cell. And these different copies of the virus, these are the virions. They are literally cut by the molecular scissors called neuraminidase. Okay, so that all these particles get out of the respiratory epithelial cell and attack other normal respiratory epithelial cells. This particular neuraminidase, action of neuraminidase, is blocked by oseltamivir. And that is the most important thing that our listeners must understand, that earlier you give this oseltamivir, this particular release of these virions from the respiratory epithelial cells to the other normal respiratory epithelial cells, and progression of the disease is something which can be prevented. As said, there have been some major global pandemics: 1918, 1957, 1968, and 2009. After every major pandemic, one type of virus continues to stay in the atmosphere. Okay. And for example, now H1N1 pandemic strain of 2009 still lingers on, okay, in the atmosphere. Dr. Anil, we have been discussing about this virus and this H1N1 and H3N2 now. So during this year, 2025, what is your experience about the epidemiology and circulating strains of influenza virus in the pediatric population in India and in your area?
Yes, sir. Thank you very much. Good evening, everyone. Sir has already given us the KYC details of all the viruses, influenza A, influenza B, and influenza C. And sir also has already explained us regarding the concept of the shift and the drift. That is, the antigens keep changing. If it's a minor variation, the variation is very minimal, so that these are all locally circulating viruses. But if there is a sudden shift, like H1N1 becomes H9 something, then the shift is too severe, then that strain will become a pandemic virus. And like what Sarah has told, the pandemic virus of 2009, that is the H1N1, is still around, going around. And this is what we got in the year 2025 also. The season began somewhere in June, and probably we are towards the. It usually it's a biphasic kind of a thing. What we see here in Bangalore. So the first phase is probably getting over, and we are getting into that small second peak or the winter peak, usually which happens. So in the first peak, we saw more of influenza A. In that also being very particular, we saw more of H3N2 variant was more. And the pandemic strain of 2009, that is the H1N1 variant, was also seen. Both of them caused moderate to even severe illnesses only. And we did see less number of cases of influenza B. It was there, but very less. I would say if we had seen 7 to 8 patients of influenza A, probably 2 or 3 patients of influenza B is what we saw. And uh, in relation with the vaccination, what we are seeing, WHO keeps monitoring these strains, what is going on in the community, what is going on in the northern hemisphere, what is there in the southern hemisphere, and they adjust their vaccine accordingly. And now we have been hearing about this new trivalent vaccine. Earlier we were using trivalent, then we went on to use a quadrivalent flu vaccine, and now the talks are that from here on 2025, the recommendations from the WHO is again to go back on the trivalent. That is, we had this influenza B, which is named on the lineages like Victoria, Yamagata, and all that. So the Yamagata strain has not been found in circulation for a few years now. So the Yamagata strain recommendation in the vaccine has been removed. So going forward, we'll be proceeding with the trivalent vaccine. So I think the same vaccines we saw in circulation also in 2025.
So that's a very good piece of information. And one must remember that the transmission of flu virus basically is, through the droplets. And these droplets, they are released when people with flu cough or sneeze or talk. And these droplets land in the mouth or the nose of the people who are nearby. And from the nose or the mouth, the virus, starts its journey down the respiratory system, and it can reach the lungs very rapidly. And that's why, the problems like ARDS or even simple pneumonia, for that matter, develops very fast in case of these children. Okay. We come across different clinical scenarios with which influenza virus presents in the pediatric population. And Dr. Anil, you have been in the intensive care setting also. So, in short, when would you suspect influenza infection, and what are the different clinical scenarios which you came across?
Yes, sir. Influenza, typically we can remember that as an acute febrile respiratory illness. So when I say acute, usually the fever is of very acute onset. Within 1 or 2 days, the fever is of very high grade fever, and it's a very febrile respiratory. That means the fever is so much it causes little bit of congestion in the nose, throat. Usually, little older children will be able to complain of the very severe sore throat, and they may have a non-productive cough in the initial period. On day 2, day 3, they start having severe rhinorrhea, myalgia, malaise, headache, body pain. Like sir already told, even little older children may have such severe myalgia that they may have to be carried. And also this happens with a backdrop of the epidemic. Usually onset of the monsoons will be there, and we start getting lots of children presenting with the similar complaints. And usually families, the entire families will, when we ask them is somebody else sick at home, they will say that there have been other cases of similar illnesses in the family also. This is about the mild cases, and also because it's a virus and it can cause a multisystemic involvement, we do see other system involvement also. Like they may have children may present to us with vomiting, diarrhea, and we have seen that because of high fever, the neurological system is the one which gets involved next after the respiratory system. They present with increased cases of febrile seizures in this season. We do see because of high fever. They may have a febrile status epilepticus and rare complications which have been described in the textbook, like our myocarditis and acute necrotizing encephalitis. These kind of rare complications, they do happen. When we talk to our other colleagues, they keep telling that we had this complication this year, this complication. So the flu, as sir told, we can't take it lightly. It can be a self-limiting illness to a very severe illness also.
Sure. And of course, individual respiratory viruses have their own presenting features, and we will see some points related to what I call it as educated guess related to the viruses and the bacteria. So we now know the presenting features of influenza. However, some of these children who get influenza, they become serious. And Dr. Anil, would you like to tell our listeners about some of these emergency warning signs of flu sickness, so that we all are aware as to when to inform the parents to report back to the medical emergency or to the treating doctor?
Yes, sir. These are the red flag signs that I think we all should watch out for. Like, sir, again, as I think given as a complete gist of everything, sir told more of cytokine involvement, more of immune system involvement is there. So these signs can happen within a matter of, say, a day or two. Also, this children's stable child can become unstable. So the parent should be educated about these warning signs. So basically, when we look at it as to what these warning signs are, this is kind of helps us to categorize the severity or the sickness. If the child is becoming too lethargic, too drowsy, unable to eat or drink on his or her own, or the activity in the interfebrile period starts reducing, a child is totally not accepting feeds, becomes very irritable. These are the general warning signs that we look out for. System wise, if we look at it, respiratory system, if there is any low respiratory tract involvement, these are the pneumonia warning signs that we look out for. That is, the child starts having a severe cough with chest retractions, fast breathing, becomes tachypneic. Sometimes, if it is too severe, the breathing distress difficulty becomes too much, and bluish discoloration of the skin, cold clammy peripheries. If the CVS or myocarditis is suspected, we should look out for these things. So these are the general warning signs that we should educate the parents about and tell them, please watch out for these signs, and if any of these are there, to report to the clinic or to the emergency room as soon as possible.
Right. Now, these complications of influenza could very well be summarized if we put them, starting with the alphabet A. For example, ARI, which means either acute respiratory infection because of pneumonia or ARDS, acute otitis media, absenteeism from the school, and impact on the income of the parents because of absence from the office, and also the antibiotic abuse. Remember that viruses usually they will damage the respiratory epithelium, and they will set the stage for the bacteria to produce secondary bacterial infection. There are so many viruses which behave in this particular fashion, and influenza is one of them. Also, as there is a problem in differentiating the bacterial from the viral infections, many times our colleagues land up in prescribing antibiotics, and that's why antibiotic abuse is also associated with illnesses like influenza. Now the treatment of influenza has been based on categorization of this particular illness into categories A, B, and C. And once we remember the categories, it becomes very easy to decide whether we need to give the antiviral agent like oseltamivir, whether we need to do the nasopharyngeal swab for testing. And this is something which is of great importance in the management of influenza-like illnesses, because in the beginning, the diagnosis is not certain. One doesn't know whether this is influenza or not. But then, Dr. Anil, would you like to elaborate a bit more about these categories of influenza illness clinically, how our colleagues can identify?
Yes, sir. Whenever we are seeing these cases in the backdrop of an epidemic that is going on, so we make a syndromic diagnosis of influenza-like illness. So various bodies such as WHO or even our Ministry of Health and Family Welfare, they have given us this categorization where we can easily categorize these patients into different categories based on the severity and take the appropriate steps of management, be it resource limited setting or a resource setting also. The same categorization can be applied. So to put it in simple terms, category A is our regular OPD kind of a patient. The patient will present with mild fever, cough, sore throat, body pain, severe headache, myalgia, or they may have little diarrhea or vomiting. But none of the danger signs that we discussed about, none of these danger signs are present. And these are the cases where just uncomplicated cases which will recover on its own, mildly self-limiting kind of illness, 3 to 4 days with good supportive care, rest, hydration, and home isolation is all that is required in category A. So here in this category, testing also may not be required, nor we go ahead and start these patients on a particular antiviral, in this case being oseltamivir, it's not required. Whereas the category B, these are the uh, children with moderate kind of symptoms, or they may have risk factors. So what are the moderate symptoms? These are the severity which is slightly more than category A. That is, the fever is severe, headache, sore throat, body pain. These are the ones who have much severe kind of symptoms. And also the high risk category. This would include age wise, when we look at it, any children who are aged less than 2 years, or elderly group that is more than 65 years of age. These are the ones by age they become high risk category, or others who are having a chronic health condition. So may it may be cardiac condition, chronic cardiac condition, chronic respiratory condition, children who are born extreme premature. In our case of pediatricians, we look at extreme premature children having a cyanotic or acyanotic congenital heart disease. They may have a chronic liver disease, or they may have immune suppression for whatever reason. They may be on chemotherapy for leukemias, or rheumatological condition. They may be on steroids, or it may be nephrotic syndrome also. So all these patients by default they categorize into, irrespective of their severity of symptoms, like it may be mild, but still if they have high risk any of these characteristics, they will be in category B. And category C are the severe ones, where we would end up admitting them either to the ICU or the HDU based on the if they have any of the red flag signs, or they're requiring any kind of organ support for their breathlessness or their low blood pressure, or multi-system involvement. They're requiring ICU care. These are the category C patients. So category B and category C patients are the ones who deserve to be monitored more carefully. And of course, category B, C will require a naso for the diagnosis and for monitoring, epidemiological monitoring. They would require a nasopharyngeal swab to be done, where we send nasopharyngeal or a deep throat swab for the flu panel. And these are the category where we would go ahead and start them on empirical oseltamivir. Even without the uh, testing, category B and category C would require to be tested and treated with the oseltamivir molecule.
Right. Right. Thank you for telling it in a brief and a concise manner. Now, before we proceed further, we will just have a quick look at this particular molecule, oseltamivir. And this molecule, as I told you, it blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. Oseltamivir is a prodrug which is converted into active form oseltamivir carboxylate in the liver, and this was the first oral neuraminidase inhibitor, and this was approved in more than 100 countries, and also it is approved by the Center for Disease Control, also by the American Academy of Pediatrics. We have just seen the different categories and the treatment based on this categorization, and now we are clear that for a child who is having mild presentation, usually home isolation, bed rest, and plenty of fluids and paracetamol, usually they suffice. We all know that aspirin is to be avoided for bringing down the fever because of the relation of salicylates with Rye syndrome, which of course we saw much more when we were residents, when influenza patients, would come with, problems. Then we used to rather see what was the problem, because influenza virus, when these patients are given aspirin for some reason or the other, usually creates problems akin to liver cell failure, and it was known as Rye syndrome. For categories B and category C, we give all this supportive therapy along with antivirals. And at this particular juncture, we may also do the viral testing. And for category C, we have to hospitalize the patients and give them oseltamivir and, of course, supportive therapy. It is important to note that most of these viruses, particularly influenza and RSV, they behave badly in children and adults also, who are at a high risk of so many conditions. So these high risk patients are the ones which need to be taken care of, particularly in both these conditions. The dosages and the recommendations of oseltamivir have to be understood thoroughly. For adults, the therapeutic dose is 75 milligram capsule twice daily, while the prophylactic dose is 75 milligram capsule only once in a day. Therapy is given for 5 days, while chemoprophylaxis is given for 10 days. And in children, the dosage depends on the weight bands. The details about the dosage are available along with each bottle of the syrup of oseltamivir. Syrup contains 12 milligrams per ml, and depending on the weight band, one can select the total amount and give from 2.5 ml to 6.25 ml, whatever is the necessary amount for that particular child. Now, we have seen a lot about influenza, about the categorization, and also oseltamivir. It is now important to understand as to how early initiation of oseltamivir influences the clinical outcomes. So, Dr. Anil, will you just elaborate a bit about this aspect of oseltamivir?
Yes, sir. The timing of starting of a specific treatment, in this case of influenza, starting of oseltamivir, plays a very important role to know how much duration the course will run. So, like we discussed, if it's a mild one, we don't start, so it will settle on its own. For the more category B and category C, we need to start it as early as possible. So, sir has already told us about the mechanism of action. So, this drug gets converted to a prodrug to a drug and then starts acting on the neuraminidase, which is a molecular scissor. So what this does is it prevents the release of these virions from being released from the infected cell. So it multiplies there in the infected cell into thousands and thousands, and then it is released. So by blocking this release, what we are doing is we are preventing the spread of this virus from the host cell to the other surrounding cells and the organs. So thereby we are preventing the complications of the disease. So multiple studies have told us that starting this particular molecule oseltamivir within the first 24 to 48 hours can reduce the duration by 1 to 2 days. So thereby limiting the duration of the illness, and also by preventing the, it helps in prevent the complications of the disease also. There have been multiple studies. Also in referral centers, we do see that sometimes children are referred to us on day 4, day 5. So in the backdrop of this epidemic of influenza that is going on, so even for those patients, they are also deserving patients where probably already complications have started to set in. So even in those cases, we go ahead and start them on oseltamivir, be it day 4 and day 5. Even in such cases, we have been able to prevent the complications and also limit the duration of illness. Even if it is started late, it's of benefit. So empirically, I think we should go ahead and start even with or without the swab, this preferably within the first 48 hours of illness, it gives us the better result.
Right. And all the points that Dr. Anil had just told have been substantiated by WHO. So WHO has said that empiric treatment is strongly recommended. The treatment should be started as soon as possible, and the laboratory confirmation of the influenza virus is not necessary for initiation of therapy. Sometimes the laboratory tests, they don't come positive in spite of the child having this influenza virus, and that is because of some technical reasons, or some areas where the skillful collection of the nasopharyngeal swab is not done. But even then, one should always respect the clinical presentation in the epidemiological setting, and think whether oseltamivir needs to be started depending on the categories that we discussed. Of course, we will discuss some cases so that some of these points become further clear. So, Dr. Anil, this is a child who has come to us with fever for 3 days, cold and cough, and he is on metered dose inhaler since 4 months. The fever is well controlled, and this child receives symptomatic therapy and comes back after 3 days. He remains half febrile only for a day. Of course, he has been active in between, and the fever has reappeared. Again, the parents are worried because they say that why this infection has recurred, and why these infections are getting more frequent. We all are aware of this phenomenon, and we know that these are occurring at shorter intervals, and we really don't need antibiotics every time. But then it's important that you also convince the parents and take a outlook which would convince them. So, Dr. Anil, how would you counsel the parents who come with similar complaints?
Yes, sir. Of late, I think in our pediatric practice, I think this is every other patient is having the same profile as sir has been presenting now. So we do see that children are sent to school very early. Within the second year itself, 1.5, 2 years, a child is going to a pre-nursery, pre-toddler. They may call it by very fancier names, but they are in a daycare setting. Few of them accompany the parent to work where they are cared for in their work settings. So they're getting exposed. Multiple exposures are there. And we know for little older children, the such exposure had not happened in the COVID era also. For 2, 3 years, they were kept indoors without much exposure. So it's obvious for a parent, for a child who is going through such frequent infections, the parent also becomes very anxious. Like sir told, it's very stressful for the parent, loss of absenteeism. They need to stay back to take care of the child and all these things. So they are also very, very anxious and they come to us with such complaints. So it's difficult because it's time consuming, energy consuming to counsel, talk to such parents and to counsel. But spending a couple of extra minutes with the parents, understanding what is the exact stress point over here, which is affecting the family. We understand that, we show them, we plot the child's height and weight on a growth chart and show them child is falling very much within the percentile and the centiles have not dropped off in the last few months. So, and also we do a thorough clinical examination, rule out any major illnesses, and reassure the parent that these are all minor upper respiratory infections which the child is bound to get in this age group. And this is how the child is learning the immunity. Sometimes I've gone ahead and told them that please consider a cold and cough, common cold, as one more member in your family till the child grows up, till the child becomes 5, 6 years old. We can be rest assured that minor cold coughs are going to stay with you and your child. And spending those extra time will definitely help, sir, in such patients.
Right. It is very important, and everyone must understand that the parents, they are not aware of all these things that Dr. Anil just told us. So tell them that these, viral infections, even up to the extent of about 8 or 10 viral infections, are normal in the growing child per year, and one need not worry till the child is growing well. And you can show them the growth chart so that they are convinced that the child is not having any underlying major problem. As I always like to tell our listeners about these identification of the enemies, some viruses, particularly like rhinovirus, they come with cold and sneezing, and they are the ones which are restricted to the upper airway usually. Though recently I came across references which stated that rhinovirus is not that benign, but overall, we have considered rhinovirus as a virus for the upper respiratory tract. And, these children are the ones who usually play well. And these children are not the ones who are from the serious category. Influenza, as I said, behaves more like a systemic illness because of so many reasons, which we discussed related to the direct epithelial damage and the cytokine related problems. So they come with prominent headache, myalgia, extreme exhaustion. And para-influenza viruses are the ones which can come with a presentation like, croup, where there could be inspiratory stridor. And adenoviruses usually have a different presentation. Many times they come with pharyngocongenital fever and sometimes with diarrhea, mesenteric lymphadenitis, or hemorrhagic cystitis. And under the age of 1 year, respiratory syncytial viruses come with bronchiolitis. Again, mild fever, but more of, episodes of respiratory involvement in the form of wheezing and breathlessness. Okay. Some of these bacteria, particularly group A beta hemolytic streptococcus, it produces fever with follicular tonsillitis and tender cervical nodes. Pneumococcus has its presentation with pneumonia, which comes with fever, grunting, and tachypnea. And Staphylococcus comes with a rapidly progressive illness and a toxic presentation. And mycoplasma usually affects older children predominantly with cough. These are general guidelines wherein one can just try to figure out as to what is the offending organism and whether one needs to do anything about it. Whatever is the organism, it is important to know that the child is observed for worsening of these conditions, because all of them, either would be self-limiting like viruses, or they may progress, they may need antibiotics, but in the beginning it's very difficult, and that's why one should be aware of the danger signs which we discussed, like the sensorium of the child, whether the temperature, in viral infections usually temperature comes down as the days progress, while in bacterial infections initially the temperature may not be that high, but the temperature continues to rise high. Even children, in case if they are worsening, they may develop oliguria, the perfusion may be on the lower side. So all these problems need to be observed. So observation of this child, follow up is very, very important. This was another child, a 4-year-old child with cough and fever of high grade since 5 days, and was not settling with oral medication. And on admission, the child had tachypnea and needed oxygen support. This child had total count of 1620 and the platelet count of 132,000, with derangement of the liver functions. And the nasopharyngeal swab was positive for H3N2. And this child was diagnosed as influenza with low WBC count and low platelet count. This is a picture which is many times seen in our practice. So, Dr. Anil, I would like you to just explain as to how you would proceed in the management of such children.
Yes, sir. This is a very, very typical presentation and referrals we get usually on day 4, day 5 of illness when the child is becoming more sick. And especially with the backdrop of if it's the onset of monsoon and we are in the midst of influenza season, this is we would approach it syndromically only. So when the child comes to us, we would make a syndromic diagnosis of influenza-like illness. So straight away, when we categorize, this child will be in the category C because the danger signs are there because already day 5 of illness, not fever is not settling, child is already tachypnic and requiring oxygen support. So red flag signs are there. So this child is in category C. So depending on the distress and our resources, we will admit them either in the HDU or the PICU. And as with any respiratory illness, if the child is sick enough, we place IV cannula, give all the supportive care, oxygen, nebulizations, and whatever paracetamol, whatever is required. And this is a situation where the child is sick, so deserves to be started on an antibiotic based on the protocol. And amoxiclav, co-amoxiclav is the antibiotic of choice for respiratory infections that we start with, and based on the institute protocol. So we'd place a cannula, take blood culture, start on IV antibiotic, and we should not forget to start on empiric oseltamivir, antiviral with the backdrop of this epidemic of flu that is going on. We should. I think once after a few hours, we will get the blood reports, the chest X-ray, all these things. So getting blood reports, total counts of thousands, 1600, maybe there is a transient bone marrow suppression, which is suppressing both the platelet counts are borderline and total counts are low, again suggesting that this could be a viral etiology itself. And when we look at transaminitis is already set in, SGOT and SGPT are elevated in hundreds. And again, kind of confirms us that there is some viral etiology that is going on. So better to cover this child with the specific antiviral that is a oseltamivir. And the nasal swab, depending on our resources, it may be available in few, but few places like Tier A cities, Tier B also it may be available. But little interior, we may not have the facilities nor the affordability for these tests. So this is where the empirical coverage will work. And as and when the swab becomes available, that is kind of confirmatory to tell us that this was secondary to influenza.
Right. Here we can see that the presentation has been like the respiratory viral infection progressing to maybe pneumonia or condition like this. And I'm sure our listeners who are aware that arthropod-borne diseases like dengue can sometime coexist along with this influenza virus, may also be responsible for leukopenia and low platelet count and derangement of liver function. So it is better to be aware of the co-infection. And of course, when the presentation is more respiratory, it's more likely to be influenza. However, it is also prudent to be aware that dengue can coexist and accordingly observe, because both these illnesses may worsen on day 4 or 5, and unfortunately you might be facing some situation which could be serious. There was another child who was also H3N2 positive, and another one with normal counts and CRP38 again turned out to be H3N2 positive. There was one child who deceived us, where of course the WBC count was high, the CRP was also high, and fever was continuously very high. And this turned out to be adenovirus positive. It is very well known that adenovirus and some other viruses, they usually behave in a bit of a different way. And we have seen these viruses like adenovirus or human metapneumovirus producing picture like lobar pneumonia and fever continuing for a long time, child receiving ceftriaxone for almost 2 weeks, and then someone comes across the presentation that adenovirus also can produce similar picture. Dr. Anil, this is another child, a 5-year-old girl with high fever for 5 days, cough and cold for 5 days, sick with mild wheeze, no crepitations. Now, given this clinical presentation, will you put this child on antibiotic, and how would be your approach about similar cases?
Yes, sir. It's always a syndromic approach. Probably this will be again, if you say it's already 5 days and child is already sick looking with little bit of respiratory symptoms, probably again we would classify this child as category C, and antibiotic we always start. If the child is looking sick, it's always prudent to start antibiotic after taking cultures and empiric oseltamivir also. And then based on how it progresses, then we can always de-escalate once it we have a good assessment over the first 24 48 hours, and depending on what our labs and the nasal swab shows, we can always de-escalate later on.
Sure. So this child was put on IV amoxiclav. WBC count was 2800, neutrophils 10, lymphocytes 70. The CRP was 34.7. This child was put on oseltamivir, and the nasopharyngeal swab showed rhinovirus positivity. Now, many of us who have the facilities for doing the nasopharyngeal swab and getting the reports fast, uh, you know, we would like to know as to what is the sensitivity of these, nasopharyngeal swabs. What is the sensitivity, particularly of influenza PCR, and how do we base the treatment decisions on that?
Yes, sir. The latest generation of PCR is quite sensitive. So a well-performed PCR test, like if the swabs are taken from deep within the nasopharynx, anterior nasopharynx, or from the deep within the throat, the sensitivity is more than 95%. That means it is able to detect if the virus is there more than 95 times, it will out of 100, it will detect that it is positive. Means it is picking up the true infection. Whereas the specificity is also good. If it is well taken, well collected, it is good. But many a times we are not unsure like how the collection has been done. So then the sensitivity will drop down to 60% also. So I think we should approach this with our clinical acumen over here. We should make a syndromic diagnosis with the backdrop of we should know how much influenza is going on in the community, for which doing regular swabs also will help. In our sicker patients, we do a swab to know what virus is going around in that season. And also the acute febrile illness, like respiratory kind of illness, kind of a presentation, high possibility of this influenza we should keep in mind. In this situation, the nasopharyngeal swab has shown positivity for rhinovirus. And like how you describe, we should know the clinical syndrome, what the virus can present. So rhinovirus, as we know, it's an important virus in a small babies, which can cause localized kind of a thing. They causes lots of nasal congestion, lots of rhinorrhea, and a localized kind of a disease. It causes mild grade fever, body pain, and gets better. Very rarely in small children can cause pneumonias, but in a big child like this, rhinovirus causing pneumonia in a well child is little unlikely. So if you have a strong possibility of it being a influenza-like illness, and there is no other causative organism to explain it, I think it's worthwhile to continue with our oseltamivir and complete the 5 days of treatment in such scenarios.
Right. Thank you. Now, this is a 7-year-old daughter of IT sector parents coming to us with high fever for 3 days, throat irritation. She has her school exam after 2 days. The throat is showing mild congestion, The child has been put on paracetamol. The flu and the adenovirus cases are there in the atmosphere. And that's why the parents who are highly educated IT sector parents, they want to know as to whether we need to investigate and send the throat swab, whether one should start with empiric oseltamivir. So how would you speak to these parents and decide your treatment?
Yes, sir. We come across this situation quite a bit, especially if it's a flu season. We have a high incidence of both flu as well as adeno can cause similar kind of symptoms. So if you review these systems and the symptoms again, we are seeing that there is fever of 3 days, mild throat irritation is there. Apart from that, mild nasal congestion, throat congestion, there is nothing much that is happening. So if the child is otherwise active, interfebrile period is well, so this would still be a category A kind of a patient where symptomatic supportive care is more than sufficient. Coming to the other social issues that they may be pressurizing us for an antibiotic or further testing, whether testing is required, antibiotic is required, antiviral is required. Most of these viral illnesses are self-limiting, so I think we should buy time over here. If it's only 3 days, we tell them this is a could be a self-limiting illness, so let's not over investigate or over treat in such a situation. So we talk to the parents, tell them none of these danger signs are there, so it's okay to wait and watch in such a situation. Neither testing nor empirical treatment is required in such a situation. We always call them back within a day or two and tell them that we are there. If at all any such danger signs are there, we will definitely investigate with a swab or start a empirical oseltamivir. Will take a decision. But since none of the red flags are there, we can still counsel them and ask them to follow up closely, sir.
Sure. So now this is one more child, a 3-year-old boy coming for cough for a week, high fever for 3 days with crepitations. The child is put on co-amoxiclav and admitted for persistent fever. This child has been put on IV amoxiclav. The WBC count and the CRP are almost normal. But the throat swab shows influenza A positivity, and that's why oseltamivir was added. Now, after adding oseltamivir, the question is we stop the antibiotic which has already been started, and there could be many and antivirals are given simultaneously to those children. So how would you look at this situation and what would be your treatment decision?
Yes, sir. This is again a classic situation that we come across. So once we have started them on empirical oseltamivir, and if it is flu, we see that they respond very well. So within 24 hours, that sense of well-being can be there. The fever spikes will start going down, and by day 2, day 3, they're almost kind of getting better. So in such a situation, this is a question of antimicrobial stewardship also. So we have started an antibiotic here, but we have done a testing where we expected it to be flu and it has come back as flu. So I think this is good enough evidence to go ahead and start the child on, stop the child, stop the antibiotic which is going on in such a situation. So I think judicious use of antibiotics is very much required need of the hour. So I think in such a situation we should go ahead and stop the antibiotic, but we should continue close monitoring. If at all there is recurrence of fever, say after 48 hours there is a fever, or there is signs of localization, we should keep checking the child for the throat. If at all the follicular crypts are filling up, there is some follicular tonsillitis or some lobar consolidation which is developing, or a secondary fever which comes up, we should always have we should follow up the child closely and start antibiotic if required.
Sure. So this concept of antibiotic stewardship is very important. In addition to these cases, which predominantly came with respiratory presentation, we had a case, 1-year-old child with fever, cough, and cold, but came with status epilepticus, and the nasopharyngeal swab showed H3N2 positivity. The counts were normal, and the MRI done showed non-specific encephalitis changes, and the CSF was normal. And this was a case of influenza encephalitis. So, in brief, Dr. Anil, I would like you to inform our listeners about the neurologic complications of influenza, so that they are aware that influenza is not only respiratory but also can have other complications.
Yes, sir. Like we already discussed, since it's an abrupt onset of high-grade fever, we see higher number of febrile seizures. febrile status epilepticus. Few of them go on to have a febrile status epilepticus, and rare immune-mediated complications like ANEC, acute necrotizing encephalopathy, secondary to influenza, we have seen, and also GBS. It can induce GBS, and sometimes GBS mimicking kind of a situation also can be there because of severe muscle pain, and neuropathy can happen. Both can happen. Myopathy can happen. Neuropathy also can happen. And of course, few cases of aseptic meningitis are common in this season where flu is going around.
Okay. It is important to note that we can have associated RSV infections along with influenza, and we must manage both these problems together. And the respiratory complications, in addition to otitis media and pneumonia, also can include exacerbation of chronic pulmonary conditions like asthma, particularly in children above 2 years, hospitalized patients. And there could be some children who can have toxic shock syndrome. Occasionally, rarely, one can have influenza with myocarditis. And that's why, right from the beginning, when you examine a child, just as one should look for the sensorium, also look for disproportionate tachycardia. Tachycardia, which is disproportionate to fever, usually indicates myocarditis. We also should know that in boys between 6 to 9 years, particularly with influenza B, there could be myositis, which can involve bilaterally gastrocnemius and the soleus muscles. And children can come with severe bilateral calf muscle pain and inability to walk. I already told you about the Rye syndrome, which is seen in patients of influenza B who are exposed to salicylates. Fortunately, this condition is now seen to a lesser extent, and even the causation of this particular condition is now being changed to some other mechanism. There are some quick questions, and Dr. Anil, maybe you can just tell our listeners, in case if elder sibling of an 8-month child is admitted with influenza A for LRTI, and this 8th month child develops fever, whether one should start oseltamivir for the younger one.
Yes, sir. Already we have an index case in the family who's diagnosed, and the younger one is becoming symptomatic. Plus, more so, this child is in that high risk category because of the age, 8 months, less than 2 years, we take it as high risk category. So, this case, we would go ahead and start the child on not the prophylactic dose. We would go ahead and treat the child in twice a day dosage for 5 days.
Okay. In addition, maybe, if a child has influenza in the family, what is the policy about giving chemoprophylaxis to the household contacts?
Household contacts, high risk contacts, yes, sir. Everyone needs to be started on these chemoprophylaxis. But whereas a healthy adult, like they don't have any comorbidities. When I say comorbidities, it may be a high risk, like we told, a grandmother who is like diabetic or a hypertensive, chronic cardiac condition or immunosuppressed. All these patients will definitely need to be on chemoprophylaxis. Whereas a healthy adult, we can just adopt the wait and watch kind of a criteria.
Right. So I am now sure that our listeners have got fair idea about influenza and the role of oseltamivir. And one should remember that this particular disease is the one which transmits from children to the adults. Okay. COVID usually transmits from adults to children. And that's why for influenza, one has to be very careful, when you are dealing with children. So vaccination is also primarily aimed at children. And so many things which we discussed were related to children. And in case if there are some high risk individuals in the family, one has to be more careful because, usually everyone likes to cuddle the children, take them close by. And, even in our clinics, many times when we handle children, they directly cough on our faces. And many times I'm scared. So I always wear the mask in the clinic so that, I am protected myself from influenza. Otherwise, our work would suffer, isn't it? So this particular virus is a fast and a furious virus with abrupt onset, high transmissibility, rapid progression, and even complications like ARDS would develop very fast. And that's why we have to also give oseltamivir very, very fast in the first 48 hours. Okay. Many of us might be still under the impression that, oh, what is there? Influenza is a mild illness. But please remove that concept from your mind. Those of you who have seen complicated cases would really understand the importance. And from all the discussion that we have had, please, try to look at this particular subject with a lot of seriousness. In addition, one has to be aware of certain preventive measures like sanitation, mask, and social distancing, following the cough etiquettes like coughing in the elbow, and following certain rules related to the hand, which I call as Hasta Pancha Sutri, 5 rules related to the hand, like frequent hand wash, avoiding handshakes, using a handkerchief, and keeping the contacts at a hand's distance, and avoiding hand touching. This virus sits on the tabletops, laptops, doorknobs, and so many things, and that's why it is better that you take care of all these surfaces also. And one more important preventive measure is the flu vaccine. So whenever you celebrate your birthday, please remember, in addition to saying happy birthday to you, always say happy birthday to flu. And please see that you take this particular vaccine. Not only you, but also make it a habit to give it to all in the hospital, the staff, the ward boys, the ayas, the resident doctors, everyone, and see that they are also protected, because they are also equally exposed to this virus when a patient comes to the OPD. So with that, we come to the end of today's discussion, and I bid farewell by saying namaste for all the important reasons that I told you, and more importantly, to develop it as a habit to avoid the spread of these contagious viruses from one to other. Thank you.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Thank you very much. Thanks, Dr. Anil. Thank you. Thank you very much, sir. And thanks all the doctor who took time from the schedule and attended this webinar. Thanks IT team, Sai Shirkar. Thanks sales and marketing team of Hitro. We can sign off, sir. And wish you a very pleasant evening. Thank you.
Thank you.
Thank you, sir. Thank you so
Thank you.
much.